The next speaker, we would like to introduce Professor Stephen Davis from Australia to have a talk about the advanced brain imaging for selection of late IV and IA reperfusion. Thank you.
Good morning. I hope this is all going to work with the audio, and again, thank you very much to our Vietnamese hosts for this wonderful meeting. I'm going to talk to you about advanced imaging in selection for intravenous and intra-arterial therapies at late time windows. All of reperfusion in stroke is based on the concept of the ischemic penumbra, which is somewhat like a tropical cyclone, with an expanding core shown here and swirling hypoperfusion. And the problem in stroke is that every patient is different. So penumbral fate is individual, and it depends on collaterals and whether or not reperfusion occurs. So our old concept that time is brain has really been replaced by individual assessment of patients using imaging and clinical parameters. We do know that with the penumbra declines over time. So this was early work done by David Darby with our group in Melbourne. And the concept of late treatments beyond the initial thresholds for intravenous therapy and endovascular thrombectomy was really the finding that many patients had penumbra beyond 4.5 hours or 6 hours. And this has been replicated in other recent work using MRI, and this group found that every hour results in an average decrease of 3 mils of penumbra and an increase of 3 mils of core volume. But the problem is this is an average, and we know patients are individuals. Greg Albers showed this very clearly by dichotomizing patients into fast and slow growers and looking at the initial endovascular thrombectomy trials, the time between symptom onset and thrombectomy, to show where treatment response was likely to occur. So you can see here these trials where there's a rapid expansion of ischemic core volume, and other trials where the expansion was somewhat slower. Particularly the late window trials are really selecting patients with more prolonged penumbra. Now, we can measure the penumbra in an automated fashion, as you know, with MRI or CT perfusion. The initial reports were, of course, with MRI scan, showing a mismatch between perfusion and diffusion, so PWI and DWI. So the perfusion measured the tissue potentially at risk, and the DWI lesion measured the region of the brain that was generally, although not always, irreversibly damaged. And when you saw this mismatch pattern, this was an opportunity to treat at later time windows. MRI has really been replaced in most centres by CT perfusion because it's easier, it's more widely applicable, the thresholds are well defined using a Tmax of 6, and basically you can see here the hypoperfusion region and the core, which is generally measured at less than 30% of normal cerebral blood flow. So CTP is what I'm going to mainly talk about this morning, but of course MRI is still used in some centres, and MRI can be used to predict later treatment responders. And this was, of course, shown in the Wake Up trial from Gottstamala and colleagues, where there was a mismatch between diffusion and flare. They showed that in patients with unknown time of onset, if you did an MRI scan and you showed a diffusion flare mismatch, these were treatment responders to TPA. And if you had that pattern of mismatch, there were better outcomes with TPA than placebo. In fact, this pattern probably mainly reflects patients treated within 4.5 hours rather than later onset of treatment. And although quite convincing data, it's CTP that is really being used around the world. Now, we've all lived with the idea that TPA has a 4.5-hour threshold, and that's, of course, based on unselected patients from all the trials, just patients' clinical criteria, non-contrast CT scan, and then that's the treatment window that was established from the trials. Recent publications, and you're going to hear from Henry Ma next, who of course led our treatment trial going up to 9 hours in patients with wake-up stroke, and our group then looked overall using perfusion imaging at doubling the time window to 9 hours, and in wake-up stroke showing the treatment benefits. But it was Extend that really broke the time window and doubled the time for intravenous thrombolysis. But Extend depended on advanced imaging with CTP. So CTP was used in this extended time window. We excluded patients with an infarct core of more than 70 mils. They had to have significant mismatch and a significant perfusion deficit. And this is the classic mismatch pattern that we used, and I know Henry's going to talk about this a little further in the next talk. So when we look at the primary endpoint in Extend, you can see here that there's a significant benefit with TPA. This was the adjusted relative risk and a very positive result. And further, the benefits were in patients with mismatch between perfusion deficit and core, in other words, those with a penumbra. And interestingly, in patients that didn't have mismatch in this extended time window, there was no benefit. So the evidence at this time is if you want to use intravenous reperfusion with TPA beyond 4.5 hours, you need to use advanced imaging, and CTP is the standard that's easiest to apply. There's some further evidence also from the TWIST trial, recently published, which looked at wake-up stroke within 4.5 hours after waking up. And this was a trial of TNK versus placebo based on non-contrast CT. So there was no advanced imaging. And in this trial, treatment with tenecteplase was not associated with an improved functional outcome. So selection with non-contrast CT and intravenous tenecteplase didn't show a positive result. So this is translated into guidelines that you can use advanced imaging to select patients beyond 4.5 hours with either CT or MRI showing core perfusion mismatch, and there is a strong recommendation for use of intravenous thrombolysis in this window in guidelines around the world. So let's now turn to thrombectomy and look at the late window story. And there's been a lot of additional information from larger trials going out to 24 hours. Now, we all know that thrombectomy is a standard of care for large vessel occlusion. It's incredibly powerful. It's a much more powerful treatment than stenting for coronary artery stenosis, coronary artery occlusion. And we all know about the late window trials of mechanical thrombectomy, which really confirms selection using the penumbra, the Diffuse 3 trial headed by Greg Albers and Noguera and Joven with the Dawn trial. Very, very powerful selection of patients. They, of course, excluded patients with large ischemic cores, highly positive results, and in a way they were so positive that it immediately prompted the question, are too many patients being excluded by, for example, having large cores? And the other question that it prompted was, is, can simple selection criteria, this is such a powerful treatment, can we just use simple non-contrast CT to select patients? Do we need anything more? So these are the results that you're familiar with. So the guidelines from a few years ago indicated that at that stage, Dawn and Diffuse 3 were the only trials showing a benefit of thrombectomy beyond 6 hours, and that therefore if you're going to apply this to clinical practice, you had to use the eligibility criteria in patient selection. So there was level 1 evidence, level 1A, but you had to use mismatch criteria. Now the Hermes collaboration utilised the data from the initial thrombectomy trials, and the important thing is that the ischemic core is strongly prognostic but didn't alter treatment effect. But if you look here at the ischemic core and the likelihood of a good functional outcome, let's just look, for example, beyond 100 mils. You can see here that in control patients, the outcome was dismal, with very few patients achieving a functional outcome, an MRS of 0.2. Then if you put endovascular treatment on top, there's a significant a p-value improvement right out to 150 mils, but the improvement in absolute terms is very small, and I'll come back to that. So the issue is, should large ischemic cores be excluded? Because the Hermes data suggested that even patients with large ischemic cores, there was some treatment benefit. And the debate, which is still unresolved, is how much imaging is needed. Can you just use non-contrast CT, where the changes are relatively subtle? There's some questions about inter-rater agreement, although aspects is validated. Can you use multi-phase CTA, or measurement of collaterals, another way of selecting treatment responders, or CT perfusion, which is very easy when it's automated. You get an automated measure of the infarct core and the perfusion. It's very simple to interpret, and it's very useful in selecting patients for thrombectomy. So CTP before reperfusion therapy in advanced time windows is standard in Australia with telemedicine and hospital therapy. It gives you an accurate depiction of core and penumbra. It makes it easier to diagnose distal vessel occlusions, makes it easier to exclude mimics. It stratifies the need for transport for endovascular therapy, and ischemic core is the best predictor of outcome. And as I'm going to sort of emphasise, patients are complicated, and particularly those with large cores and comorbidities, and knowledge with precision of the ischemic core is very helpful in discussion with relatives. Now that is not advancing. I'll just click this one. So Tan Nguyen did a very simple study looking at non-contrast CT versus CTP and MRI in large vessel occlusion, and she found that CT and CTP selection produced similar clinical outcomes. So this is one of these studies. This is just a cohort study, and I'm going to focus now on trials in the debate that favours that the non-contrast CT might be adequate. We also have information from Mr. Clean Late, which is a late time window trial of endovascular therapy versus no endovascular therapy, 6 to 24 hours. Patients were excluded if they had more than 1/3 MCA damage on CT, and they had to have collateral flow on the CTA. And this trial was positive, although didn't quite statistically make it on dichotomy of MRS 0.1 and 0.2. But I think it's very interesting to compare Dawn and using the much more selected approach with advanced imaging and Mr. Clean Late. So both trials are positive, but Dawn is much more positive using advanced selection. So if you look here at independent function, the benefit of Dawn is 49% versus 13%. Mr. Clean Late, it's about a 5% difference, 39% and 34%. And in fact, on dichotomy, it wasn't quite significant, but it certainly was on a shift approach. So the concern has been, well, use advanced imaging, maybe we're over-selecting. With CT, the benefits are less clear and it's somewhat more difficult to apply in clinical practice. Well, we do have quite a lot of new evidence from the large core trials. Large cores probably make up about 20% of patients with proximal artery occlusions. So just briefly overview these trials and try and bring all this together. So SELECT-2 was a trial of large cores out to 24 hours. You could select patients either with aspects 3 to 5 with a large core or having a volume of more than 50 mils of CTP core, although most were over 70. CTP was used in nearly all patients. I was on the Data Safety Monitoring Committee of this trial, and it was rather agonising to watch the data come through, because very early on it was evident that the trial was going to be positive. And the trial eventually showed a difference of MRS02 of 20% versus 7%. And the results of either selection method were fairly similar. And there was a treatment effect even with very large volumes, but there was a very low likelihood of independence. And that's where I'm going to come back to the basic theme of individualising the patient and individualising therapy. You heard from Bernard Yan yesterday that the Rescue Japan Limit trial mainly used MRI and MRI aspects to measure the large core. Again, a positive trial. Again, you can see a very limited treatment effect, although clearly significant, 14% versus 8%, so a 6% absolute difference. There was some increase in intracranial hemorrhage. A little bit more difficult to translate because of the MRI dependency. Angel aspects from China, again, either aspects 3 to 5 or infarct core 70 to 100, used rapid automated selection. CTP was used on all patients. Treatment effect, whether it was CTP or aspects, fairly similar. And again, the trial was stopped early for efficacy. Very high rate of reperfusion, somewhat better treatment effect in terms of likelihood of patients achieving MRS of 0.2. And then finally, the Tesla trial, which to my knowledge not yet published, presented recently, only used non-contrast CT, aspects of 2 to 5, and they had a pre-specified probability of superiority. The trial didn't quite achieve this, technically not a positive trial, but the results are very much in line with the other trials. And we've heard yesterday that the Magna collaboration will be looking at all of these late window times trials to determine the overall benefit. So the trials suggest that you can use non-contrast CT or CTP in late window trials to select thrombectomy. With CTP, you're probably giving more specificity to the selection protocol, and it's certainly easier to apply in practice. Here's a study looking at CTP aspects, in other words, aspect score measured by perfusion versus non-contrast CT, the standard way of looking at aspects. And here's an example of a patient treated at 90 minutes with a large left MCA stroke. You can see this large reduction here on the cerebral blood volume, very, very striking. Initial CT scan, there's some very, very subtle early changes, but very difficult to see the infarct. And this is, which is clearly evident on the blood flow on the CT perfusion scan. And this is the follow-up non-contrast CT showing a very poor outcome. So this study showed that CTP was better in terms of inter-rater agreement and improved prognostic accuracy, particularly in patients treated early. CT aspects perform better in later treated patients, although not as well overall as CTP. So let me try and bring all this together. Why use CTP in large core? Now, I know in Vietnam some centres have CT perfusion and many centres don't. Doing perfusion CT adds a few minutes to your standard non-contrast protocol. It's very simple. When you're doing bridging therapy, once you've gotten the non-contrast CT and ruled out hemorrhage, you can give the thrombolytic drug before finalising the CT perfusion. But it aids discussions with families. You get a precise estimate of the core, which is incredibly valuable in discussing prognosis and the likelihood of a treatment benefit. If the patient's young and there's no disability, don't mess around with the size of the core. We just treat the patient. In other words, the core provides information, but we treat nonetheless. But patients are complex, as you all know as clinicians. If the patient's old, they've used a walking aid before the stroke, they might have an advanced directive that they don't want to live with severe disability, then some families will decide after discussion that they don't want to proceed with thrombectomy. I think the important thing to remember is that patients are not p-values. You've got to individualise. Many patients are elderly. They've got premorbid Rankins that didn't allow them to participate in trials of endovascular thrombectomy. They might have some cognitive impairment, and it certainly, in many countries, advanced care directives are very important in discussions with families. So advanced imaging adds specificity, and it certainly selects better treatment responders. There's no good evidence that you exclude patients by using CTP. It's an aid to discussion, and I think one needs both perfusion core on CTP and some concept of the actual damage on non-contrast CT in discussion with families. Clinical decision-making is complicated. So advanced imaging improves your diagnostic precision and your ability to estimate prognosis on top of non-contrast CT. It has to be used for delayed intravenous thrombolysis, and Henry will talk more about that. And I think it's ideal and adds value to non-contrast CT for delayed thrombectomy, 6 to 24 hours. And it's not going to allow me to advance, but thank you very much for your attention.
Thank you very much, Professor Davis. So, any question from the audience? Yes, please.
Steve, thanks for a nice overview. I wonder whether one of the sort of limitations of both CTP and MRI is ultimately inference about the penumbra metabolism, but actually there's still ultimately measurement of perfusion, blood flow. So is that the sort of rate limiting step, is that it's an indirect inference of the metabolism, but it's not truly measuring metabolism?
Yeah, well, that's a fair point, Craig. I mean, originally the penumbra was defined, as you know, on measures of oxygen metabolism and the oxygen extraction fraction. So these are all estimates, you're quite right, and probably more indirect than the initial estimate of penumbra with 15O PET. But it seems to be clinically useful and reasonably validated in studies.
Steve, thank you. Very nice overview. One thing that I always try to tell my trainees is that don't look at CTP as an absolute cutoff for something. And the story here is that CTP criteria were defined from diffuse studies, and they excluded the presumed large cores. They showed the benefit of thrombectomy, and then SELECT-2 gave them a surprise result. So my question to you in your debate, why SELECT-2 showed such a surprise result? I have a theory, but I would like to run it by you.
So I think that there's no doubt that there's some patients that there's mismatch between CTP and non-contrast CT. And I think the principle when in discussion is that thrombectomy should be used unless you've got a pretty good reason not to use it. But you do have to have discussions, I think, with patients and their families about what the absolute benefit is, what the patient's wishes are, and the decision-making is more complex than selection in clinical trials.
My theory is also that diffuse, the original ones, they're 20 years back. And we did not have effective reperfusion therapy back then. And so seeing a large volume of 70 or 100 mils was a self-fulfilling prophecy. It was big. We didn't have good, effective treatment strategy. Therefore, it's predictive. As mechanical thrombectomy evolved, SELECT-2 showed us this is relative. And so it pushed the boundary. So I think you're right. If you only don't do thrombectomy when you have a good reason not to do it.
So I think we're in a situation where there's one point of view, just thrombectomize everyone because there's a statistically significant benefit. But you have to look at what the absolute benefit is, and you have to look at the patient in front of you. And remember that many of the patients in front of us don't match what went into the clinical trials. There's no doubt Diffuse-3 and Dawn highly selected treatment responders and probably overly selected the treatment responders. But I think we're in a situation where most of us would agree you don't offer everyone thrombectomy.
Any other question? So I have a question for you. Another question, please. David. One more question for me.
Yep.
Yes, I want to ask that in Vietnam there is some center that can do the thrombectomy, but they don't have the perfusion imaging. Yeah. So with such a result, can we apply the using NCTT to that?
I think that in centres that don't have perfusion imaging, you use aspects and you use other standard criteria. I think the big question is when you see an aspect that's very, very bad, 0, 1, these patients were not in the trials and you generally would not treat. It's the 3 to 5 group that has been shown to be useful to thrombectomy in the trials, but you have to take into account all of these other individual patient factors. So the bottom line is, yes, if you don't have CTP, non-contrast CT with aspects, I think it's well validated in selection for thrombectomy, but I think if you have CTP, you get a much more accurate estimate of the core and you get other information that I think helps decision-making.
Okay, thank you very much. So we move to that next speaker. We'd like to introduce Professor Henry Ma for the topic of updates in thrombolysis and its future. Please.
Thank you, Chairman. Thank you, everyone, for inviting me to talk about thrombolysis. I feel like every time I come here, I talk about thrombolysis. So this time I actually made a special effort to talk about things that I haven't really talked much about in the past. So in fact, I've no COI to declare. This is probably the most important slide for the whole talk. I wanted to concentrate on the latest information for the last 1 year. There has not been a lot of large-scale thrombolysis trial published in the last year. So a lot of the information I contain here today are of lower level evidence, smaller scale, but give us some food for thought and some idea to think about how do we apply thrombolysis. Don't take it as gospel, take a bit of grain of salt, but I think they're interesting informations. So firstly, thrombolysis and time. Professor Davis has already spoken about extended thrombolysis time window for 4.5 to 9 hours using CT perfusion. And there is clinical benefit, But there is a recent study published looking at a multi-center cohort study, looking at particularly this cohort patient of 4.5 to 9 hours with more than 15,000 patients. They show that in this cohort study, applying thrombolysis in the extended time window, the outcome is exactly the same as 0 to 4.5 hours. But if you look at Professor David's talk too, if you actually apply advanced neuroimaging to select patients for thrombolysis in this extended time window, you actually get a mortality benefit. So then we always ask the next question, what about up to 24 hours? Professor Greg Albert conducted a study called Timeless, announced the ESOC this year. I have not seen the actual publication yet. They're basically a phase 3 RCT, TNK versus placebo, 4.5 to 9 hours, using perfusion imaging selections in patients with large vessel occlusion, M1, M2, and ICA. More than 400 patients admitted, moderate severe stroke or aspect of 8, did not reach a primary endpoint of MRS in 90 days, but there was some interesting information. If you look at a patient with M1 occlusions, TNK, and if MRS 0 to 2, TNK was about 46% versus placebo of 31%. And complete recanalization was higher in TNK compared to placebo. There was a slight trend towards benefit in the TNK cohort in shift analysis. We'll come out ratio of 1.13, but p-value was actually 0.48. What's important thing is that TNK seems to save in this extended time window, but about 3 versus 2% of hemorrhage, but we'll wait for the full paper. So want to advertise this in Australia, we're doing eternal study, very similar, using TNK to extend time window versus best medical therapy. Our sample size is 740, it's ongoing, and hopefully we can finish this one soon. So let's look at bridging therapy. What is the role of thrombolysis? Bridging therapy, most people look at what's the role of thrombectomy, but in fact I look at what's the role of thrombolysis in bridging therapy here. So we all know there are quite a number of large publications and study on direct versus bridging, which I'm not going to go through in detail. But if you actually look at it, it's a bit of a mixed information. The one I put in green are kind of positive. The one I put in red are kind of negative, so-called. If you look at direct MT, it's actually non-inferior. DEVT is non-inferior, non-superior. SCIP is not non-inferior. Mystically no IV, superiority not demonstrated. Switch direct is non-inferiority not demonstrated. And direct save is non-inferior, not demonstrated. So it is a bit of a mixed bag to me, because also the margins are different, cohort are very different. But we're also waiting for the pool analysis, which was actually announced last year in WS, so I'm still waiting for the full paper. With the pool analysis, they were able to demonstrate that direct mechanical thrombectomy is not non-inferior to bridging therapy at a 5% margin. So that was announced. I'm waiting for the full paper. So let's break down a little bit more what I said, a little bit of, lower level evidence, but it's interesting things. If you look at patients with what we call fast progressor, these patients have more than 15 mil per hour growth of the infarct using perfusion imaging. And if you look at it, the fast progressor respond much better to bridging therapy than direct thrombectomy. And they are, in terms of their smaller infarct volume and better 3 months MRS outcome in fast progressor having bridging therapy. In fact, that was echoed by the secondary analysis of direct MT. If you look at direct MT, the patient who randomized from randomization to groin puncture time of more than 33 minutes, the patient who received bridging therapy did better than direct thrombectomy. Basically, what it means is that when you're actually giving TPA, if you've got a long time to your cath lab, probably actually bear some benefit by giving bridging therapy. So what about patients who actually fail to recanalize or partial recanalize? So fail to recanalize, we get TICI of 0 to 1, or partial recanalization is TICI to A. And in this study, it's a retrospective cohort study, they found that prior thrombolysis helped to improve functions functional outcome, and even mortality in patients who fail or actual partial reperfusion, meaning that thrombolysis actually help to improve functions even though these patients didn't have a good recanalization outcome. But what about patient transfer? We all have patients who in our rural country area or in what we'll call the primary stroke center need to go to the comprehensive stroke center for thrombectomy. And this is a review of 6 studies with more than 1,000 patients. And they look at the patient who had TPA before transfer, had more favorable outcome in terms of excellent functional outcome and all-cause mortality compared to a patient who did not have thrombolysis before transfer. So what about basilar artery bridging therapy? Now, this is a little bit older, it's 2022, it's about a year and a half old. So it's more than 1,000 patients looking at basilar artery bridging therapy versus direct thrombectomy from 3 studies, more than 1,000 patients. They found that bridging therapy was favorable in terms of mortality and MRI-02 outcome in basilar artery occlusion. So let's look at the location too. So this is a study looking at patients with mild clinical stroke, large vessel occlusion. It's another retrospective study, nearly 600 patients with mild stroke. What they have found is the further you go out, the further distal you go, the more likely you benefit from thrombolysis. If you go down to M2, it favors thrombolysis more than bridging therapy. But as you would expect, as you go to the proximal M1 ICA, it favors bridging therapy. What about different clot location? So this is looking at medium vessel occlusion, basically M2 vessel occlusion. They show that patients with M2 occlusion don't do well if they don't reperfuse. But the patient who receive TPA tend to do better than they don't receive TPA. And the patient recanalized do better than patient not recanalized, as you would expect. But this is an interesting study looking at M2 occlusions in terms of what are predictors of futile recanalizations. It's a German stroke registry looking at patients with M2 occlusion. The futile recanalizations often happen predicted by patients with severe premorbid pre-stroke MRS, diabetes, and number of passes. But what's really interesting is IV thrombolysis reduce the chances of futile recanalization in M2. So it seems to work more in the distal vessels, the thrombolysis. What about ACA, anterior cerebral artery stroke? In the topmost registry, A2, A3 thrombectomy look very similar to medical therapy. If you look at before propensity score matching, in fact, the mechanical thrombectomy looks worse than best medical therapy, but once you've done propensity score matching, they look very similar. But what about PCA, small P2 and P3 thrombectomy versus that medical therapy? This is published just this year, looking at thrombectomy. It looks better for disability, but ownership. But if you look at it, the spread of MRIs is a little bit, strange to an extent. But anyway, higher odds of early NIH improvement and similar odds for disability by ordinal shift. But if you look at the next study, which again, looking at PCA occlusion, this is a multi-center study, it gives a different results. It's our observational study, proximal PCA. They found that thrombectomy not associated with good or excellent outcome with higher rate of symptomatic hemorrhage and early neurological deterioration. So I think the answer we still don't yet know because a smaller artery, we definitely need better RCT on this. So what about we look at a cohort of mild stroke patient with a large vessel occlusion? The patient came with NIH of 3 or 4, but with a large vessel occlusion. And in this cohort, you're looking at extended IA cohort and a pool international cohort. They show that this patient within 4.5 hours, NIH is less than 6. There's no difference between thrombectomy and medical therapy. But in fact, thrombectomy had higher neurological worsening and symptomatic hemorrhage compared to medical therapy. As Professor David says, if you actually apply perfusion imaging and found the patient with perfusion mismatch, target mismatch, This actual patient respond better, as you can see the mid-Gaucher bar. The patient who had perfusion mismatch with thrombectomy did better than medical therapy. So perfusion imaging helped you identify this sort of mild stroke patient who will probably do better. And this is a bit of in contrast to the last study, but this one is just a registry study and not stratified by perfusion or advanced neuroimaging, and show that in mild stroke, large vessel occlusion, in this registry study, thrombolysis plus thrombectomy has poor functional outcome. Again, but this is not stratified by perfusion imaging or advanced neuroimaging. And we move from proximal artery to now more distal and smaller vessels. What about M2 and mild stroke? This is a meta-analysis. What it shows, quite interesting, in mild stroke patients, NIH less than 5, thrombectomy was better for M1, from best medical therapy was better for M2. So that both shows in both MRI 0 to 1 and MRI 0 to 2. And that reflects similar to all the other studies I mentioned earlier. What about mild stroke by itself, irrespective of large vessel occlusion or not? This is an interesting study. It's an Austrian stroke unit registry looking at patients of NIHs of 0 to 1 versus 2 to 5. If you give TPA, a patient only got NIH 0 to 1, you actually tend to do worse than the NIH says 2 to 5. So maybe very, very mild stroke, you probably got to think twice about giving any TPA. But we don't have data on the perfusion, large vessel occlusion from this registry. But I just think it's interesting. I think this study was spoken about yesterday by Professor Donner. I'll just quickly go over it. It's basically a very interesting trial looking at open-label non-inferiority trial of a margin 4.5 in mild stroke NIHSS less or equal to 5. It's all done in Chinese patients within 4.5 hours onset. They compared dual antiplatelets versus TPA. If you look at it, the median NIHSS of 2, the interquartile range is 1 to 3. About 80% of mild stenosis, barely any, a really very low number have large vessel occlusion, as would you expect. So the intracranial hemorrhage rate you would expect is higher in the TPA group. Dual antiplatelet is non-inferior to TPA. But my actual question is, this patient you probably won't even thought about TPA anyway in the clinical setting of NIH of 2 or even 1. So what about large infarct call and TPA? There's no real actual study, but I actually look at a forest plot of the Japanese large call study and angel aspect. If you look at a forest plot of the Japanese, of both of them, no TPA favored in the forest plot. So basically patients who had endovascular clot retrieval for large call do better tend to have no TPA. So I think, that raised the reason, questions about TPA and large call with risk of hemorrhage. Now I'll come to a very difficult one, which is tenecteplase versus alteplase. So very briefly, we know tenecteplase is a bit different to TPA in terms of fibrinogen specificities, half-life, and plasma and fibrinogen conservations, and all that is quite different to TPA. This is where all kind of started by Mark Parsons back in 2012. We have a phase 2b study looking at tenecteplase versus alteplase. It showed better reperfusions and actually clinical outcome too. Then this was then followed by a test trial, which was only a phase 2 study within 4.5 hours stroke onset using CT perfusions. It shows similar result of TNK and TPA. Then we've got NORTEST 1, which was a phase 3 studies using a 0.4 milligram per kilogram within 4.5 hours without any perfusion imaging. There's no difference in the outcome, but they were pretty mild stroke. If you look at the median NIHSS is only a 4, and large vessel occlusion only 20%. And then the next breakthrough was Extend IATNK, which was led by Professor Stephen Davis and Jeffrey Donnan in Australia, looking at 0.25 milligram per kilogram TNK versus 0.9 milligram of TPA in patient with large vessel occlusion planned for thrombectomy. They also had to have target perfusion mismatch within 4.5 hours onset, and it showed tenecteplase had better clinical outcome compared to alteplase before thrombectomy. Then the next part is look at the dosage, and I think we all agree now 0.25 milligram per kilogram is the way to go, not because it shows there's no difference between 0.4 and 0.25. Then last year, this ACT Canadian trial was published. It is multi-center, it's open label, parallel group, registry-linked study. It's 22 centers in Canada, within 4.5 hours stroke onset using 0.25 milligram per kilogram and with a non-inferiority margin of 0.5. Basically, it shows that tenecteplase was non-inferior to TPA. If you look at a baseline NHSS, it's about 9 and 10, and the primary outcome was 36% to 34%. So tenecteplase was non-inferior to TPA in this cohort. Then you look at NORTEST 2, which was published again last year. This was different. It's 0.4 milligram per kilogram versus 0.9 of TPA. It had early termination due to safety concerns. Unfortunately, if you look at the Grotter bar, the tenecteplase actually did worse than alteplase. And if you look at a major neurological improvement, there was 74% in alteplase and 58% in tenecteplase. Symptomatic intracranial hemorrhage, 1% versus 6% that was terminated early. I suspect that's all mainly due to the 0.4 milligram per kilogram dose. And then we see this year TRACE-2 study, which is a phase 3 multi-center open label randomized controlled non-inferiority trial within 4.5 hours of stroke onset. Really important, they excluded thrombectomy or planned for thrombectomy patients. So this is a different cohort of patients. NIHSS of 5 to 25 inclusion. They used non-con CT or MRI for selections. They found that in non-thrombectomy patients with pretty mild moderate stroke, NIHSS of 7 median, TNK was non-inferior to TPA within 4.5 hours. It got a similar hemorrhage rate to alteplase, and the only slight issue is that it's mainly Chinese populations for generalizations. But in general, it shows non-inferiority in non-thrombectomy patients. Then we'll look at TWIST, which Professor Davis also mentioned earlier. This is actually looking at wake-up stroke using tenecteplase, but only using non-contrast CT for assessments. The median medication was given within 4.5 hours of waking up, and if you can see, in terms of the median NIHSS, moderate of 8 to 14 is only 28%, 27%. Most of them are mild 0 to 7 NIHSS, and only about 30% of patients had large vessel occlusion. So mainly towards the mild moderate severity group. If you look at the outcome, tenecteplase in wake-up stroke using non-con CT imaging selection was not associated with better functional outcome in 90 days, although there was similar level of intracranial hemorrhage. If you look at the Kaplan-Meier curve, there seems to be for mortality, although non-significant, slightly higher there. Certainly the symptomatic hemorrhage was very similar of 3 to 4%. So in wake-up stroke, non-con CT, tenecteplase was not non-inferior to TPA. So let's look at some of the real-world use of tenecteplase. This is a systematic review of off-label use of tenecteplase. Basically 6 studies, nearly 2,000 patients of off-label use of tenecteplase. That shows that tenecteplase was associated with early neurological improvement and successful recanalizations. This is a recent publication from last year looking at thrombolysis of tenecteplase using SITS registry. All these patients were eligible for IV thrombolysis within 4.5 hours. So basically all patients. So tenecteplase versus TPA in all cohort, they had better 3 months functional outcome, lower all-cause mortality, and no difference in symptomatic ICH. So we thought about patients having tenecteplase in hospital. What about putting tenecteplase in the ambulance? So as Professor Davids mentioned earlier, TASE-A is a tenecteplase versus alteplase in the stroke ambulance, ultra-fast, ultra-early treatment. Again, we use 0.25 milligram per kilogram. What it found that tenecteplase has reduced perfusion volume by the time the patient reached hospital, and of 12 mil versus 35 mils of alteplase, and there was no safety concern. And in fact, if you actually use any ambulance, there is shown to be a positive cost effectiveness, probably driven by the lower cost and greater benefits. And then for longer term model, tenecteplase also had more health benefits, and it reduced costs for rehospitalization, nursing home care, and non-medical care. So what about tenecteplase in patients with large tandem clots? Because we always feel that patients with large tandem clots, they don't do very well with thrombolysis. So what about tenecteplase versus TPA in this cohort patient using extended IA data? They found that there's no difference between tenecteplase and TPA with or without tandem lesions. There was also no difference in mortality and symptomatic ICH. But if you look at the grotto bar, the patient without tandem lesion, tenecteplase tends to do a little bit better than alteplase, although not significant. So we always worry about hemorrhage risk with thrombolysis, and we always think, tenecteplase probably better in terms of hemorrhage rate compared to alteplase. Most studies show that tenecteplase and alteplase are very similar in terms of the symptomatic ICH. This is a retrospective observational study of more than 100 hospitals. Basically shows tenecteplase has lower hemorrhage risk compared to alteplase. So these Australian guidelines, AHA, the American guidelines, level 2B, but Australian guidelines, there's a strong recommendations for using tenecteplase in patients with large vessel occlusion, and a weak recommendation to use tenecteplase in patients without large vessel occlusion. So if I can try to summarize all this together in one way. Tenecteplase before thrombectomy, extended definitely, I think it's enough evidence to use tenecteplase over TPA for patients with large vessel occlusion before thrombectomy. Tenecteplase for all stroke, the Canadian ACT trial shows tenecteplase was non-inferior, but it was an open label registry link trial. There's an ongoing trial, which is an LCT TASE by Australian, run by Professor Mark Parsons. Hopefully we can finish this and give more definitive result from LCT. What about tenecteplase for non-thrombectomy patients who are not for thrombectomy? Trace do suggest that tenecteplase is non-inferior, but these mainly Chinese patients. What about tenecteplase and wake-up stroke? Twist studies said, well, no, not with non-contrast CT. So there's no evidence of using tenecteplase for wake-up stroke using non-contrast CT selection. What about hemorrhage risk? It seemed quite similar. In fact, the study I showed before probably is better than alteplase. What about in extended time windows tenecteplase beyond 4.5 hours? Unfortunately, timeless was negative is the primary outcome, but the secondary outcome looks quite very interesting, and hopefully more data will come from our eternal trial. So one more slide. I'm not sure people are still interested. Pro-urokinase actually was actually compared to alteplase. This shows a similar effect and less hemorrhage risk. So summary, if we can. Thrombolysis is still an effective reperfusion therapy. In the era of thrombectomy, thrombolysis still has a significant role to play. As I mentioned today, the area of interest is how does thrombolysis fit in bridging therapy? There may be certain cohort patients benefit more from bridging therapy with thrombolysis. Mild stroke, distal occlusions, the role of thrombolysis, and reperfusion therapy for patient transfer from primary stroke center to comprehensive stroke center. What about the battle between tenecteplase and TPA? We still a little bit more information, but to me, I think we're going to the final countdown. And I think, if you ask my own opinion, I think it's going to be non-inferior, similar to alteplase with similar outcome. Thank you very much.
Thank you, Professor Henry Ma. Any question from the audience? Yes, please.
Nice talk, Henry. Can I just ask 2 questions? The first one is, why do you think the TPA is better for the distal vessels? It's sort of counterintuitive. On the one hand, you'd think that a bigger clot, less effective, but if there's greater flow, then it's more effective. So that's the first question. The second thing is, I just wonder if you could just elaborate on some practical dosing issues of TNK, rounding up and discarding vials and ease of administration. So practicality of TNK over alteplase and the occlusion story.
Thanks, Ray. Excellent questions. The first one I have to postulate, there is clinical trial shows that if you give post-thrombectomy alteplase, there is increased so-called microcirculation, cleared up smaller clots and better functional outcomes. So maybe alteplase or thrombolysis, it's better for smaller clots rather than large clots and hence distal vessels that maybe. I don't know the full answer. I have not seen anyone giving me, unless Professor Davis have a better answer. I don't know if there is any, I have not seen any biological paper published about this. The second question was dosing. So what? 4.25 is 0.4. Sorry, I didn't miss that.
No, in our place, TNK comes packaged for cardiac. You have to repackage, unpackage it, and package it for stroke. That's the dosing difference. So 0.25, but you have to change the vial so you're not accidentally give cardiac dose. That's
yes.
Just the practicalities of throwaway, unused amount of the vial, because there's different ways of doing it, and I know you're looking at the direct costs, but maybe there's some indirect wastage costs. So I haven't used TNK, I'm a novice, so tell me about the practicalities of dosing up TNK in the field versus alteplase.
Well, I think probably Professor David's going to answer. I mean, basically, most patients can just need one vial. Is that correct, Steve? You don't have to throw them out because per kilogram, one vial usually enough. Not like TPA where you have to use usually 1.5 vials.
Yeah, the beauty of TNK is you just whack it in.
Yeah.
And there's no 1 hour infusion. I think the evidence is you get faster reperfusion because you're giving the full dose straight away rather than a 1 hour bolus without safety concerns. So, yeah. It's usually 1 vial.
Usually 1 vial. And that's where cost saving is. You don't have to throw away the second vial.
All right. Thank you. Great overview. It's like tour de force of all the trials. So a quick remark about timeless. Timeless is not generalizable because the time from TNK versus control administration to thrombectomy was 19 minutes. Have you seen anything like that in real life? So this was primary, that was admission to comprehensive stroke center. And there was no time for TNK to work. You showed a beautiful slide that analysis showed. If delay is more than half an hour, give it, because that's real life. You're not gonna get to thrombectomy in transfer. So stay tuned. I think we cannot dismiss TNK just based on timeless for that matter. And then if you can make a comment that's important to hear, because when we say TNK, we mean specific TNK, very specific. And unfortunately, worldwide, there are multiple TNKs. So comment on this.
Yeah. Thank you for pointing out. I think timeless, we just need to get the whole paper. And I did hear Greg talk about the delays on to the needles. So I think, in terms of tenectoplase, yes, I think TNK really means tenectoplase. But alteplase, there are some different forms of it. And I think we did clarify that.
Okay, I would like to ask you the roles of TNKs in a minor stroke. Does it mean that the patient needs inferior 5?
So the paper I saw, they did not really specify the dosage because I think there are registry, a lot of them, and hence I think I don't have the information for that, for those minor stroke, because the trials accept no test, the 0.25 milligram per kilogram, but the registries observational trial, I don't know the dosage.
Okay, thank you very much for a very interesting presentation and also a very active discussion. Now we move to the last talk today. We would like to invite Professor Andrei Alexandrov to come to the stage to talk about minimizing the risk of hemorrhagic after reperfusion, IVT and EVT. Please.
Thank you very much. These are my disclosures. So what are the issues remaining with intravenous TPA or intravenous thrombolysis, I should say, and mechanical thrombectomy? So optimal blood pressure is still unknown. The guidelines are very generous, and I'm going to examine that. If you intubated the patient for one reason or the other, you're losing exam, so you don't know how safe it is. Even though the numbers reported in clinical trials of symptomatic hemorrhage appear reasonably low, it is not zero. And when you implement thrombolysis or thrombectomy in your place, there is a learning curve, and where a bleeding rate might be higher, so beware of that. And then issues such as reocclusion and continuous embolization, that poses the challenge when to bring the patient back to the cath lab. So my personal bias through the whole stroke saga was using transcranial Doppler even before CTA was available. And so we were able to see occlusion, recanalization, reembolization, reocclusion processes in real time. And here is an example of how you can monitor the patient during thrombolysis, before thrombectomy, or most importantly, after thrombectomy, what's happening with successful or not successful reperfusion. And I will come back to that slide. But to use this technology the right way, you need to have a head frame fixation. So that would allow you continuous sampling of blood flow changes. And you can use TB classification of residual flow signals. It's thrombolysis and brain ischemia waveforms that allow you to predict persisting occlusion or beginning of recanalization, partial recanalization, or complete recanalization. And when we published it, we only had TIMI flow scale, but now we have TICI. And so the same classification can predict TICI grades, thrombolysis and cerebral infarction, specific to cerebral angiograms. You can see the occlusion process in real time. There is the trace in the middle cerebral artery. You can see resistance changes that would imply certain severe problems. And you can also see recanalization and reocclusion in real time. And that's just one of the first cases when we saw tandem lesion responding to IV TPA treatment, and then only losing the battle of continuing reembolization from proximal ulcerated ICA stenosis. And that was actually one of the first cases where we did what is now standard of care bridging therapy. We did IV TPA, and then we took the patient to the cath lab trying to finish this tandem lesion and carotid T occlusion. So we found with TPA that reocclusion is common. It can occur up to a quarter of patients, particularly treated with IV TPA with just proximal MC occlusion. But that was a long time ago. That is previous century data. So let's fast forward to present time. So here is typical case of M1 MC occlusion presenting in a 60-year-old person with an IH stroke scale score of 17, good aspects. Patient is right within the 3-hour time window, gets IV TPA, CTA gets transferred, and CTA shows persistence of the MCA occlusion. And the patient is taken for catheter angiography. Here is your TK0 here, and here is TK3. Beautiful reperfusion, one pass. That's how it's supposed to work, right? High five. And that is achieved with a drip and ship at 246 minutes. So it seems like a good thing. So then the patient goes to the intensive care unit, and the patient's blood pressure is kept under the guidelines up to 180 over 105. Okay, systolic, diastolic, up to 180 over 105. And 8 hours later, decreased level of consciousness, and repeat CAT scan shows this. I hope by now, most of you who treated patients with thrombectomy have seen images like that. If you haven't seen images like that, that means you're on the uptake of this technology. Be prepared that you will see cases like that. So what is it? So we use colloquial term contrastoma. So it's a combination of contrast and the blood products with extravasation. How do you differentiate how much contrast, how much blood? You need to do dual energy CT scan if you have that, or you do MRI essentially, and then you see how much contrast and how much blood products is. But let's think about what was happening here with the tissue. And the result of that, unfortunately, is that modified Rankin score is 4. So despite that relatively fast complete reperfusion, we still do not have good outcomes. So let's go back in time of what we learned about blood pressure with TPA, with IV TPA. So do you know how these goals were actually set? Before bolus 185 or 110, and after bolus 180 over 105 for 24 hours. Do you guys know how these numbers were selected? They were pulled out from the thin air by the NINDS RTPA stroke study investigators. When first pivotal TPA trial was planned, investigators were given parts of the protocol to write. And two famous guys, who should remain nameless in this discussion, pulled out those numbers. Why those numbers? Well, if you're having acute ischemic stroke, you don't want to drop the blood pressure. In fact, Craig, you showed in one of your trials that very low blood pressure is no bloody good. So you want to lower it down, but not too much. And that's why they thought that these numbers would be kind of giving you safety thing. But they didn't want to be very aggressive in lowering the blood pressure. And it turns out that their guess was right. That subsequent studies showed that violations of these blood pressure parameters, spiking of the blood pressure, volatile blood pressure, leaving blood pressure way too high, results in increased risk of symptomatic hemorrhage. But are these ideal numbers? I don't think so, and I'm going to tell you what we learned from our studies. Also, the higher the systolic blood pressure, the less a chance of recanalization with systemic therapy, presumably because the higher the blood pressure, the more proximal the clot burden and the more severe stroke the patient is developing. So keep this in mind when we're going to talk about this case. I showed you this sonogram. This sonogram was the first documented complete M1 occlusion recanalization with IV TPA alone. That was before thrombectomy. We did this case like way back in 98 or 99. And we were so excited to see this, that from no flow, you get to the full flow, that we send this sonogram to Circulation, and the Circulation journal put it on the cover of Circulation. Thankfully, the reviewers didn't ask what happened to the patient. So this is this patient. He was a 70-year-old man with an NIH stroke scale score of 15, right M1 MCA occlusion, full right MCA syndrome. Got towards the end of the window, kind of we were realizing that probably we were pushing the envelope, and recanalization occurred probably after 4 hours from symptom onset. So, and it was a severe stroke. And we kept his blood pressure by guidelines. He was under 180 over 105. But what we didn't pay attention at that time was the velocity. The velocity was 75 centimeters per second in a 75-year-old man. That is generous velocity. In fact, many of us in this room will not have this high velocity. So, however, we were excited to see complete reperfusion. Interestingly, he did not improve with this recanalization. He continued to have NIH of 15, We admitted him, and 2 hours later, this is what happened to him. It was massive, fatal intracerebral hemorrhage. So in retrospect, that's a wonderful tool in medicine. I recommend you highly using it. With retrospectoscope, this was hyperemic waveform. So hyperemic reperfusion after a TPA or thrombectomy is very analogous to cerebral hyperperfusion syndrome that was described early after invention of carotid endarterectomy. And Steve, you probably remember that you have a patient with a chronic stenosis that someone cleans up the artery real fast and lets the blood rush into that brain, and that brain is not ready. That brain is dilated, and this is the patient with TIA or a minor stroke. Now imagine if you have damaged brain that is already vasodilated and paralyzed, probably because of injury to the vessel wall, the more severe stroke. And so what vascular surgeons described, that when you release the clamp, particularly in patient whom you are doing endarterectomy under local anesthesia, the patient with cerebral hyperperfusion will complain of a headache on the side, and it can follow seizure, and subarachnoid blood extravasation and bleeding can occur. So we think, based on our TCD findings in hundreds of patients that we monitored, that it contributes to hemorrhagic transformations, symptomatic ICH, increases edema, contributes to neurological decline, and interestingly, can provoke seizures after stroke. So, and I just want to let you know, it's my personal bias right now. When I'm consulted on a patient who is subacute, with a subacute stroke and first ever seizure, we not only repeat the CAT scan, but I also, and not only give Capra, but I also look at blood pressure. And if blood pressure exceeds 140/80, my bias to bring this patient blood pressure down to normal tension, because that delayed hyperemic reperfusion can be the mechanism, one of the mechanisms of seizures after stroke. The good news is that this is directly detectable by TCD, okay? And it basically shows that velocity is bounced to above normal values or above contralateral side at a lower pulsatility index. So that means there is more generous diastolic flow and the vessels are not autoregulating. And these CAT scans are just examples here of this hyperemic reperfusion. So, and Marta Rubiera from Barcelona published this criteria when we were monitoring pre-thrombectomy our endovascular therapies. So fast forwarding to past year, this is the study from Austria, and where patients received mechanical thrombectomy. You can see a nice result. They did TCD, they found these hyperemic signals, but they also did multimodal MRI to quantify that hyperemic reperfusion. And you can see here that this is a beautiful thrombectomy result, but look at the complex lesion that formed. It has edema, it has a hemorrhagic transformation component, and it has this hyperemic reperfusion. So how often does this happen? So this is their study diagram. So they screened a decent number of large vessel occlusions. So they found 230 eligible patients. So this is their outcomes here. And I will bring you to this point. Out of 226 large vessel occlusions reperfused, MRI or TCD or both showed hyperemic reperfusion in 33% of patients. So think about improving safety of mechanical thrombectomy, not only preventing symptomatic hemorrhage, but also preventing any hemorrhage that will actually untie your hands for early use of antiplatelets and anticoagulation. So think about this opportunity. And this is just a snapshot of their data. Now, I mentioned to you that there is now cerebrolysin data in this setting, and here is the Serihetis study, which is an 8-center trial, controlled trial of cerebrolysin versus placebo, essentially, for giving it early, right at the same day as TPA, and looking for reduction of symptomatic and asymptomatic hemorrhage. And as you can see here, the symptomatic hemorrhage right here was reduced from 9% to 2.6% in a reasonable setting of over 300 patients included into that study. So that is the study that was completed in Russia and published in BMC Neurology in March this year. So, in conclusion, and I know that clinical trials are on the way, particularly results of BEST-2 just became available, so there is still some uncertainty how to best navigate this whole situation. But to me, one upper threshold is not enough. We need to have shades of gray in our blood pressure management. And how I do it, and disclosure here, this is my personal opinion at the moment until clinical trials are done. But I think the management of blood pressure should be driven by TICI, final TICI, and neurological examination. So let's examine these scenarios. Ideal scenario, you achieve TICI-3 with either TPA or thrombectomy or bridging therapy, and you have neurological response right on the table. Patient is moving. This, to me, is the best case scenario, and this patient has no need for any elevated blood pressure. You have to drive this pressure down to below 140/80 to normal tension. And so if I haven't started a drip, blood pressure medicine drip before thrombectomy, I will definitely start it right at the end of thrombectomy. As soon as my endovascular person says, I'm done, TICI-3, it's the winner. Next case scenario, you have TICI-3 and no neurological improvement, or TICI-2 of whatever A, B, C, D, how many numbers they're going to get after 2, plus some neurological improvement. So you have either scenario that you're too late, or the brain is stunned, or there is a no reflow phenomenon on microcirculatory bed, or you have some salvageable brain is responding, but there is a residual lesion. There is either clot or pre-existing stenosis or something that doesn't allow you a full reperfusion. In those patients, I would be okay with moderate control, just allowing blood pressure a little bit high, but not too high to 180/105, because that's a really, really high pressures. And then there is this scenario. No recanalization. So you yanked that vessel 6 times, you didn't open it, and there is no improvement, okay? So some of my colleagues would advocate permissive hypertension up to these numbers, or maybe even higher numbers. So when would I entertain permissive hypertension? I would examine the patient first laying flat, and then in Trendelenburg. And if in Trendelenburg I see that the patient has neurological recovery, this is the brain that needs that blood flow, that needs collaterals, that needs this residual flow, I would be okay to allow blood pressure higher. But if I don't see neurological improvement, I would not go above 160/90. And you can say, well, that's counterintuitive here. Well, this is what we learned in our clot bus studies. Do you know what is the predictor of asymptomatic hemorrhage in patients being reperfused? It's not early reperfusion. Early reperfusion is good for you, almost invariably. It's delayed reperfusion. How do we know? We monitored the patients for 2 hours from TPA bolus. We monitored the patients till the end of thrombectomy. And if you have persisting occlusion at the end of your reperfusion therapy, that was the risk factor for symptomatic hemorrhage. You can say, well, wait a minute, this is completely counterintuitive. You didn't open the vessel, and that person is going to bleed. So what's happening with blood clots, natural history? Eventually, all of them recanalize. But that recanalization will occur hours, if not a day or 2 after stroke onset. And this recanalization will occur into dead brain, the brain that cannot protect itself. And so if you let blood pressure sit high in a patient with no recanalization and no neurological recovery, you are likely going to reperfuse large core at a really delayed time at a high blood pressure, and that's where bleeding will occur. And that's why I think the bigger challenge for us is going to be low TKs and no recanalization to control the risk of bleeding. And that's why I would still prefer that moderate control. Again, until Craig does another randomized control trial, we will not know answers, or maybe BEST program is completed, or there is another trial that's being planned during mechanical thrombectomy, because a lot of that blood pressure management needs to start in a cath lab. And so, but disclosure is, whatever goal you choose as your blood pressure, adhere to that, because it turns out that blood pressure excursions were also shown to be predictors of hemorrhagic complications. So whatever you chose, you need to stay to that target and keep the patient there. So, and I'm gonna stop here and basically thank you, and happy to answer any questions. And thank you, for organizing this great conference.
Các đồng nghiệp có câu hỏi gì không? Any question from audience? Professor, congratulations.
Thanks, Andre. One of the other big controversies that has not been resolved and still influences decision-making in blood pressure is pre-existing hypertension, because the physiology, or our interpretation of physiology, is that you reset your auto-regulatory setting in the brain, and therefore if you've got long-standing hypertension, you're more at risk of it dropping. And I know there is a trial, actually Australian-New Zealand trial, that's actually making decisions of blood pressure relative to background history of hypertension. So I wonder whether that influences decision-making at all in the older patients.
Yeah, so when we go to the emergency room and see acute stroke patients, we deal with a lot of unknowns. And so it might be safe to assume that the person who arrives had a history of hypertension, because if all the clinical trials you look, hypertension is listed anywhere between 60 to 80% as pre-existing risk factor, one of the most common ones. The question is, what were the numbers that the patient lived with and tolerated? And so the way I approach this is you're probably under the gun to treat very high blood pressures. So above 220, that's hypertensive emergency, you need to bring them down. So how do I bring them down? I don't bring them down immediately to below 160. That's too much of a fall. So I would go from, first of all, I do not touch blood pressure until I see the CAT scan. Because if there is basilar occlusion or there is a massive hemorrhage, you would have different targets. So my blood pressure starts right after the CAT scan, and if it's above 220, I would just first gently bring to below 200, re-examine the patient, and then below 180, and then the bolus. The good news for what we have, and I think that's the difference worldwide, we have short-acting calcium channel blockers. You mentioned one of them. So we can actually get them into target reasonably fast and walk the patient through from to below 200 and then below 180 probably in a matter of 15 minutes total, and have examination. If the patient arrives at blood pressure of below 200, I just bring them below 185, start TPA, and then I drive them over 15-20 minutes to below 160, and my ideal target is below 140 and above 140 but below 160. And that's assuming pre-existing hypertension, that you don't want to bust them from shifted autoregulatory curve all the way to the zone that they would not tolerate. So our blood pressure management protocol and order is very, very specific to how do you do stepwise, and that's what we teach residents. And then it becomes nursing-driven blood pressure management. So we tell the nurse, watch for the trend. If the patient goes 150, 160, 170, do not wait until they exceed 180 to adjust the drip. You titrate them back to between 140 and 160. And then once we see recanalization occurring, then we're driving pressure down if there is neurological response. So I hope that kind of long answer answers some of the concerns, but I assume that if you didn't have hypertension before stroke, you are having it now. And if you are already coming with high blood pressures, maybe you had blood pressure before, you just didn't know about it. So that's how I approach this situation. Well, if you are still... Oh, here's the question.
Dạ, em xin cảm ơn giáo sư. Và sau đây em có hai câu hỏi cho giáo sư là ngoài kiểm soát huyết áp thì trong đột quỵ cấp lúc mình thì làm sao để mình nhận diện được bệnh nhân đó là có nguy cơ cao của hội chứng tái tưới máu. Thứ hai là trong can thiệp động mạch cảnh mà bệnh nhân làm sao để mình nhận diện được là bệnh nhân đó có nguy cơ tái tưới máu và làm sao mình giảm được cái nguy cơ đó. Dạ, em xin cảm ơn.
All right, so if I understood the question correctly, it's hyperperfusion syndrome, okay? How do you define it? So the catheter angiogram cannot tell you if you have hyperemic reperfusion because your vessels look normal. The catheter angiogram can tell you trouble when you see extravasation or when you see really lots of vessels and stuff like this. But the best way to detect it directly is with transcranial Doppler. So if you just quickly measure contralateral velocity, assuming normal side is normal, and if you have 30% more increase in velocity compared to the non-affected side, and pulsatility index below the other side, you know that proportion of diastolic flow is much greater, and that's what leads to hyperemia, hyperperfusion. Okay. So I use transcranial Doppler. You can also, based on Austrian study, you can use MRI. You can take the patient after thrombectomy for MRI and do perfusion study. Okay, or you look for appearance of blood products, because if you see that there is already extravasation of blood and you achieve TK3, you can assume that there is a hyperemic component, particularly within the core of the infarct. Okay, and then obviously the longer the duration of the procedure, the greater the chance that at the end of the procedure there will be uncontrolled hyperemia.
Any question? Any other question?
So, well, if you're still thinking about the questions or no questions, well, I would like to thank the organizers and thank Professor Nguyen. This is fantastic. I mean, that's a smashing success. Thank you very much for having us here.
Cảm ơn các đồng nghiệp đã có mặt ở đây cho đến tận đúng cái giờ mà ngày hôm nay. Trong tất cả các phiên ngày hôm nay, tôi thấy rằng ngày hôm qua hôm nay chúng ta đảm bảo rất là đúng các cái thời gian. Thì hôm nay cũng là cái ngày buổi chấm dứt cái bế mạc của cái hội nghị đột quỵ Thành phố Hồ Chí Minh ngày 2023. Một lần nữa tôi xin cảm ơn các đồng nghiệp đã bỏ một cái thời gian rất dài cả ngày thứ Bảy và ngày Chủ nhật với một cái số lượng bệnh nhân, số lượng các cái người tham dự rất là đông. Năm nay chúng ta có đến hơn 900 các đồng nghiệp tham gia tại chỗ vào ngày hôm qua và khoảng 300 các bác sĩ online. Và ngày hôm nay chúng ta cũng buổi sáng chúng ta cũng đã đầy hết cái phòng này, cũng gần 600 bác sĩ và khoảng hơn 200 bác sĩ đang online. Điều đó nó cổ vũ chúng tôi rất nhiều, là những người mà chịu trách nhiệm tổ chức cái buổi hội thảo này. Chúng tôi sẽ cố gắng làm mỗi ngày mỗi tốt hơn và hy vọng sẽ được gặp lại các quý vị trong năm sau, Hội nghị đột quỵ Thành phố Hồ Chí Minh 2024. Một lần nữa xin cảm ơn các vị. Thank you Prof for attend and thanks all the speakers to come to share with us excellent talks, and it's very useful for us to to take care of a stroke patient. Thank you very much and hope to see you in the next future. Thank you.